we have our panelists back up. We're open for questions, and let me just say that when we're done here, there will be a reception right outside here, 6 o'clock, 6 to 6:30. 6:30, the dinner program starts. We have several speakers. We then have a buffet-style dinner and a keynote address. You won't want to miss it. So who's our first questioner?
I wonder if those of you who have a retainer-style practice would tell us how you handle the situation of patients who think it's a really good deal for them in the month when they have a number of procedures or illnesses, but then think afterwards they might as well just discontinue their membership and just pick it up again should they happen to need it sometime in the future.
That would be the Mitt Romney, Massachusetts Romney Care problem, right?
So, well, one, we don't have any contract. We have what we call a patient agreement that is just automatically renewing but not binding for any length of time. So they can get out at any time, and in theory they could do that. We just won't let them back in. And so for those patients who do want to hop in and out, we say, you're welcome to hop out, you just may not be able to get back in. Now, we may let some patients who fall on hard times or move away or do whatever get back in, but that's at our discretion. And so we let them know that. We'll tell them up front, I'm not shy about it. They'll say, well, I get insurance in 2 weeks, but I have abdominal pain now. Can I sign up? No, I won't make any money off that. So especially now that we're essentially full, we say, we're in this to form relationships with patients. If you want urgent care, you can go to urgent care. But for us, we just, so in that sense of making sure that there's still not a binding contract, because that might scare people away, we leave that door open, but they can leave, they just may not come back, and I think that's enough to keep them from doing so.
Can I address that as well?
Yeah.
Sorry. Yeah, sorry you can't see me back behind the podium here, but I just wanted to address that as well. We do have our patients sign a one-year contract. So the patients can't come back. I mean, once they're in, they're in. It's an annually renewing contract. Some of the practices that don't have annual contracts will charge an initiation fee. So I know like Q Alliance in Seattle, Washington, they charge a sign-up fee. And if you discontinue after 3 months and you want to come back in, you sign another sign-up fee. So it's another $100 penalty. If you're, so if you're gaming the system, you're going to keep having to pay this reinitiation fee over and over again. So a few different ways of working with it. We've not seen it as an issue. I mean, we've been doing this since January 2010. It's never come up, really.
In our practice, we have a re-upping fee. So it's not really, if somebody falls off, they do have a 10-day grace period, but if they fall off the first time, there's no fee. But we do charge them a fee if they tend to fall off over and over, and if they've done it a few times, they get put on a waiting list. And when we have time, when we have openings, that's how we deal with the folks who tend to do that.
And one last thing on that topic is that, with our patients, if they do decide they're going to terminate that contract for one reason or another early before the end of the year, if they want to come back in, they have to pay all the missed monthly payments. So they have to come current before we allow them to come back in.
If you have a question, just raise your hand and I'll bring the mic to you. Over here, okay.
Okay, I'm Lynn Tucker from Baton Rouge, and all the speakers have been great, but what we need to do is get the other members of medicine that are not with us involved, and I think we need to just get some kind of program that we can get to our news media, to the TV stations, to the radio stations, to plead our case and say, wake up, folks, this is what's happening. So what can we do?
Thank you for the advertisement for the Docs for Patient Care Foundation, 501c3 organization.
Yeah, we've been doing this.
Actually, I was going to say, I belong to an organization that's doing just that as well. It's Doc Squad, and we did a lot of radio interviews, editorials, et cetera, for that purpose, especially for the 2014 election.
And I think we're really getting there by evidence of all the media it's getting. Kiplinger's, Time Magazine, Forbes. We're seeing articles, I think, on a monthly basis where they're featuring prominent direct care doctors doing some sort of model, and it's getting, I haven't seen a negative review of it in a long time. So I think we are getting there. More and more attention is being paid to this topic all of the time.
It's becoming big business, and it's
Someone's
also
radio show has been wonderful for me.
And me too.
Yeah.
it's also been successful, so
Yeah.
that attracts interest.
I'd also say the mainstream media is reaching out now to doctors who are not part of the system. So I'm getting interview requests from people all over the country because they actually the listeners are hearing things they've never heard. I mean, people are saying, "Oh, you're so brave to say." I'm like, "No, I'm not. This is what I live this. I eat this. You guys need to know this because you're getting a bill of goods." And they really want the truth now. They're tired of people lying to them. Well, we know that. We'll stop there.
I have the mic. What I have to say is not a question, but it's a reply. And there's another group that is very specifically doing what you're asking for. And I haven't been given permission to advertise, but I'll bring you some information. But if I have permission to tell the rest of the group about it, then I will. Okay, the website is summitatthesummit.org. We are a not-for-profit organization. We are not trying to ask for members. What we're trying to do is provide a forum for individual physicians and groups such as this group to come together, bring their voices together in unity, create that critical mass that's necessary to get the attention or have the power that we need to reform policy. And thank you very much for the opportunity.
Michael Robb, Phoenix, Arizona. Congratulations to all the speakers, and it was really stellar and excellent and full of high yield information that I think the audience is pretty hungry for today. So this is a question I'd like to ask probably on behalf of some of the surgeons who might be listening to the video and or the recording. The two otolaryngologists and a neurotology surgeon, Dr. George and Dr. Giannoli, have, to my understanding, eliminated many or all third-party contracts and have opted out of Medicare, but yet you are still having a successful surgical practice. Have you chosen then to perform those surgeries in your own surgical center, in your own outpatient setting, or in a local hospital because you've made a nice arrangement with them and they've agreed to grant you the OR time and the staffing, and they're at peace with your third-party free practice model?
Personally, I do a lot in my office. So balloon sinus dilation, septoplasty, turbinectomies, polypectomies, a lot of things, when you have the right equipment, it lends itself to no longer needing to go to the OR. And I'm not totally third-party free. I don't take Medicaid or Medicare, and I'm cutting a lot of the horrible ones out of my practice. But in Atlanta, there's a lot of people who don't have insurance or high deductibles, so by definition, they're not covered either because they can't afford to go to the hospital. So when you do things in the office, a growing number actually are just the copay. So you're actually saving the patient. You're both winning in that regard. So it depends on the patient and what the insurance allowable amount and that sort of how it's set up. But if you can keep it in your office and keep the hospital and the most expensive parts of medicine out of it, it's a win for both you and the patient, and you don't have to be completely third-party free.
I do very little in the office other than the occasional PE tube and steroid perfusion. So the bulk of my surgeries are either in the surgery center or in the hospital. Obviously, the surgery center for outpatient stuff, for the hospital for things that need to stay overnight or in the ICU. As far as the patients and how they interact with these entities, if they've got Blue Cross is not paying me, but the Blue Cross often has a contract with the surgery center or the hospital. So it's just like any other surgeon. I do have a fair number of patients who don't have insurance, like the Canadian patients that come down. For those patients, I've worked out cash deals both with the hospital and with the surgery center, And in general, I like to do stuff at the surgery center just because we can get it done cheaper there.
I just wanted to add one more thing. If the patient pays at the time of service, there's a direct pay or a time of service discount. So that's another way that you can make it palatable for the patient because it's rolled into one fee. All my post-op is included. Try to make it as user-friendly as possible. So that's also something that's pretty nice for the patient.
I'm Ken Stubbs from Natchez, and I just started a third-party free practice January 1st, so I'm just feeling my way through this. I asked Josh this question just a moment ago over the coffee table, but I'm curious if any of y'all have had other experience in your other areas of the country where you're able to use, I do a kind of a monthly sign-up fee or a yearly sign-up fee. Is there any way y'all been able to work that where your patients can use that to apply to their insurance deductibles in the long run? And the other thing that I've been doing is giving them a super bill with an office visit fee and saying, if you want to go file this with your insurance, you can do that. Now, not Medicare. You can't do that with opted-out Medicare, but people with insurance. So I put a typical office visit fee on there, but I've wondered if that's really okay, because technically I didn't charge them that office visit fee. They've paid a more global type fee. And what do y'all do anything like that? Or?
You can speak to the deductible thing.
Yeah, okay. Yeah, I forgot how you do it. Well, one, this is always hard for me, and I think I learned from your slide why I don't practice in Canada is because I can't answer one question in 10 minutes, let alone two questions in 10 minutes. So, so the short version of that is I have small seizures when I see the HCFA 1500 form from my days in undergrad working for a plastic surgeon and going through that misery. So we just never did it. It felt like it wasn't thinking far enough outside of the box, like we were still evaluating that our services based on that form and if insurance paid for that form, and that was a promise I couldn't guarantee to the patients that you may or may not get reimbursed for that. And I hate doing the paperwork anyways, so then I worry they would come back and say, well, insurance said just do one more thing, right? And then now I'm the bad guy, not insurance, because I don't do the one more thing. And if it was that easy to get paid, just one more thing, we'd all be not in this conversation. So I think the value to me wasn't, I never sold it to patients as sign up for the membership and you might get most of your membership fees paid back if you see me ever. It was just, hey, this is what we're at. We're cheaper than your insurance, or we're better, or longer, or the meds are saving. So we threw all the other value we could at it and been successful that way. One thing we have done, though, is work very hard with insurance companies to see the value of the direct care membership to the point that now they're willing to accept the membership towards the deductible. We actually got an insurance company, Allied National, to do that for us. They're based not far from us. The problem was they're a TPA, third-party administrator, so they don't have full control over their underwriting. And the underwriter saw, let's say, a family of four's membership, $1,400 for the year, as an experience rating. You got $1,400 of care, you were sick, we need to charge you more next year. So even though it did apply to 1 year's deductible, it made next year's insurance more expensive. So now we're working with some bigger insurance companies like Assurant, who hopes to have a plan on for direct care within the first or second quarter, probably more the second, that will fix that and accept those fees towards the deductible. But until then, we just mostly work with the self-insured employers.
And regarding the second half of that question, where a patient comes in for an office visit that under, a third-party system, you would have typically charged a level 3 E&M visit, $82, but under your flat fee schedule, you didn't actually charge them anything. You provided that level of care. I would be really careful about giving them a HCFA form that says, the value of this service was $82, and they submit that for reimbursement. To me, that screams insurance fraud, and I would think that would be very low threshold to make that connection there. We see that a lot in patients that have car accidents, because under Florida we have no fault car stuff. Now, normally I don't see car accidents, but under traditional third-party stuff, but under Epiphany, it doesn't matter to us. A visit's a visit, so we'll treat car accidents. We don't care. Well, they then submit us a form to get reimbursed by their car insurance, and they want itemized lists of charges for every one of their visits, and I have to put this visit 0, this visit 0, this visit 0, this visit 0. It's very awkward to fill the form out, but that's what we have to do for it. So I'm not an attorney. That's not legal advice, but I personally would be uncomfortable with that.
That's good advice.
Guys,
Brian.
this is your chance, nuts and bolts questions. Yeah, go ahead.
Brian Benson from Baton Rouge. I'm 6 months out from finishing family practice, and I was wondering if you guys had some more advice for someone thinking about starting their practice this way. I just, in the few years I've been doing this, can't do this fast food style medicine. I'll fall back on something else I did prior. And so would you guys think about taking Medicare at first or opting out from the get-go? Just any advice the panel, the audience has would be appreciated. Thank you.
Yeah, your best advice is going to be from Josh, but I'm going to say the best way to quit heroin is to never start it. Okay?
You know, I have to agree with him. If you don't have to start to begin with, don't do it.
Ditto. I wouldn't do Medicare starting out again. I did it for 1 year and wished I hadn't.
The other thing you don't know is what you don't know that can get you in trouble with Medicare. Yeah. And I tell you, when I was working at Tulane Medical School, they set up a couple of satellite offices for me in physicians' offices. And I'd go to these offices once every other week or so. And then after doing this for about 3 years, the powers that be at Tulane came to me and said, "Oh, Dr. Gianoli, we have to stop that." I said, "Why?" "We found out we're in violation of Medicare laws." Okay, now this is the administration at the big university medical center. One guy by yourself, you're out of luck.
Can I make one? I'm just going to toss this to you because this question comes up a lot, and maybe if you could, I'll let him finish, and then maybe you can answer this question. There are a lot of people that try to start up cash pay practices and then do moonlighting in an ER or an urgent care that are Medicare providers. They bill Medicare, but then they try to do a cash practice on the side. And just if you, after we're done answering that question, what your thoughts are on that. Thank you.
I'm jealous of Lee for 2 reasons. One, his MRI prices are way better than mine are, and I thought I was super negotiator. 2, I've never been able to make a heroin joke come off so well in such a clean fashion. So, that's wonderful. Yeah, that's a round of applause. So yeah, I came out and it was used to residency salary. So I think in a lot of ways we didn't have the startup costs or the transitioning costs. When you've got a train that's moving, you've got 7 employees per physician, you're billing insurance, you have your contracts, they renew at different times, etc. So it probably was easier to come out fresh like that. I think in a lot of ways it was less scary. Everyone's like, "Oh, it must be so scary." Like, no, starting an insurance-based practice scares the bejesus out of me. I would probably use heroin if I had to do that. Still not as good. And so that's what I would recommend. And I've talked with doctors before when I was still a resident, and half would say, no, build a regular practice and then convert. And others would say, go straight. And I didn't understand the idea of, all right, we know the system's broken and burning doctors out, but go ahead and do that for a little while and then do what you want to do. Like worst case scenario, I build a clinic over 3 years, get 3,000 patients, convert a few hundred over. Well, in 3 years, I could get a few hundred patients myself and not, hate the whole insurance thing. So, yeah, and we can always talk. We've got the startup documents are on our website. Lee's got a bunch of stuff. I think there's a multiplicity of data out there from doctors who are doing it and are happy to share it to walk through that startup process. But yeah, go fresh.
Just to respond to Lee's point, you cannot be out of Medicare for some patients and in Medicare for others. You're personally in or you're out.
I thought with different facilities like this Moonlight facility, they have to fill out, a stack of papers for all their insurance, TRICARE, and all whatever. But that was to practice at their facilities. Where if I'm in a separate office, can't I just say I'm not billing your insurance?
Yeah, I know.
With insurance companies, whether there may be an insurance company allows that, I don't know, but I can tell you Medicare does not allow that.
You cannot see Medicare patients.
Okay.
Yeah,
right? You don't have to see Medicare patients. Yeah.
For at least a certain amount of time, yeah. It looks like it's causing you great distress. Yeah.
So this is a question for Dr. George. Dr. George, I'm in the same dilemma as you with regard to wanting to cover my office people, because I think a lot of people here all have small or micro practices and they want to, take care of their folks. And you did mention this, I was looking at United Healthcare, for example, to buy, and I noticed that they pay their 112% of Medicare or something like that. So this is a better option, I think,
Absolutely.
this medical cost sharing thing. But when I looked at this before Obamacare, you couldn't write it off. Like I think under the, what's the Christian one where you?
Samaritan or Medishare.
Yeah, and you couldn't write that off as an employer. You couldn't, but this thing you can write off as if you're paying, it's an expense for your employees' insurance, even though it's not insurance, right?
That's correct.
So in other words, that's one good thing about Obamacare. It's probably the only good thing.
It's the only thing.
For a small employer like myself, because that's probably the best thing I can know, is I now have the option, because I looked at that before, to go with these folks, pay for my little 60-year-old lady that works for me, and then also take my tax deduction.
Exactly. And then if you do AFLAC as a secondary, then you've got them covered for catastrophic, you've got them covered for office visits. That's like $14, $20 per thing. For cancer care is like $20, for ICU care is another $20. It's really cheap.
And
it's like $200.
is it any region of the country, or is it just?
Everywhere.
Okay, so
It's
basically.
nationwide.
All right. I mean, I've got employees, and did you sign up for this?
I did. I'm a member.
Okay.
Because I see the value of it. And, I'm not going to talk the talk and not do it myself.
Well, the other thing is, though, from like most insurance, when you go to get group health cover, you have to give your employees that everybody has to be treated the same. So even though this isn't insurance, I don't know, Andy, it sounds like you still probably those same laws of equity would apply, that everybody has to do it. It sounds like the doctor would have to do it too.
No, it's not insurance, so it doesn't work that way.
Okay.
It's a membership, technically. But since we all have the same mindset, you want your family of your office to
Right.
everybody be in the pot, so they're not worried. They can come to work without any kind of drama, That's really what it's about.
And you write it all off on your taxes.
I do, because I'm paying they're paying for the $199. I give them the $500, right?
Okay.
So so they don't have to have anything out of pocket. And I'm
Okay.
paying a fraction what I used to pay in Blue Cross and United Care. And no one could go because the deductible was so high. And I should say on the other side, I mean to cut you off, but for the doctor side, there's no pre-certifications. You don't have to hire people to work a claim. Okay, when it's covered, and anything medical is covered. So if it's a transplant, if it's cataract surgery, if it's a hip replacement, if it's chemo, it's covered.
And they just show up and say, I need care, and
I'm a member.
They
I
pay
pay them.
170% of Medicare.
We all share the
But
cost
the
of care.
person on the hospital.
Yeah, because it's fee for service for them.
But it is limited to 170% of Medicare, right, is what they'll pay.
That's what they'll pay, but it's covered up to $1 million per occurrence, so it's,
Right.
if the bill is $50,000, it gets covered.
Okay.
So you're not paying any more than $500. That's what you care about as the member.
Nice. Okay, great. Thank you.
They do. After about 2 months, then it gets covered at 70%, and I think it's 6 months, 100%. It just stops people from coming in with something that's catastrophic and then gaming the system.
One thing additional to say about that question, should you take Medicare early in your practice? Just my observation that most of the doctors who have been prosecuted by Medicare have been older and they have accumulated assets, and Medicare wants their assets. They take their house, their car, their office, everything. Younger doctors may be less of a lucrative target, but the statute of limitations is very long, and for fraud, I'm not sure whether there is a statute of limitations. It is so easy to trip up on a Medicare rule that I would just say, if you can avoid taking the first dollar, don't take it.
One One other comment I'd make, if you were looking at starting a third-party free practice or cash practice, the first thing you should do is join AAPS if you haven't done already.
So I have a third-party free cash practice in Illinois. Hi, Josh. This is Deborah Chisholm. Very.
We've been emailing a lot.
We have. Here's a plug for his EMR. You have to get it if you're a family practice. It's amazing. Just simple question. When people want to, everybody wants to use their flex spending account or their HSA for the retainer fee, basically, for the membership. And what's the answer I give?
I can tell you the answer I give. So I'll put a big old asterisk here that I think, for some reason, it still seems like a gray issue. We've had our accounting firm research it, and they don't think it's a gray issue. So a lot of people say you can't use HSA dollars because it's first dollar benefits. And then if you look at our accountants say, you've got IRS document 213D, which lists the approved expenses for an HSA account. It's about 2.5 pages long. Half of that, half of a page is things that aren't approved. The rest is just very global things: asthma care, podiatry, obstetrics, physicians. They list that, just very globally. So then if you go to the main document, IRS 502, it explains, I think it's 36 pages, about what are HSAs and approved expenses, and says any legal fee paid to a physician, surgeon, dentist, chiropractor, et cetera, is an allowable expense. It doesn't say concierge anywhere in the document. It doesn't say membership in regards to physicians anywhere. It says membership 4 times, twice for weight loss clinics not approved, once for gyms and spas and things, and then once for Alcoholics Anonymous type programs. And expenses to and from those types of memberships are an approved expense. So we're physicians, so I think we check. It's a legal payment, check. The other part of that is it says any payment for the treatment, cure, mitigation, management, et cetera, of. So we'll tell a lot of our patients this. We'll show them the documents. We'll provide all of it and say, now talk to your accountant. We're not accountants. We're not providing that advice. And what we find is small companies, individuals are willing to take that risk. Bigger companies aren't. I don't think it's been clarified enough for people to just go forward and say, this is definite, but at the same time, I never really understood the hesitancy when I think there's a lack of data quite as strong as that. But it's up for debate.
You should consider, if your patients have the ability, in terms of their cash flow, to not spend down their HSA, build it up, especially when they're younger, because it's a tax-advantaged account and will grow over time, compounded in a very productive way. So if they can possibly afford to pay these fees out of their current cash flow, it's probably a much better idea.
And I'm going to tell you that our accountant gave us the opposite advice. Yeah, I mean, it's really, it is a gray area that's probably not well defined. Because clearly if somebody's fee for service, that to me seems obvious that can be paid for out of pre-tax dollars. It's clearly for medical services. But when it's a retainer fee, it's not a defined value to that particular thing. It's sort of a nebulous thing to say, well, we don't really know what the value of this is. What did they get for that? What if they came in one time? What if they came in for 10 times? It's not a defined benefit. It's more, so they've told us that based upon that, they didn't feel comfortable allowing us to use pre-tax dollars for that.
Yes.
My name is Mike Casaro from Jeffersonville, Indiana. I'd like to pile on about taking Medicare early in your practice. I've been a non-participating physician in Medicare for a long time and found out about AAPS roughly a year ago. The first meeting I ever attended was January last year. Left here really enthused, went out and opted out of Medicare. Since I was non-participating, I could opt out at any time. I got my letter from Medicare saying that my opt-out had been approved. Exactly 7 days later, I got a notice from the IRS that my business was being audited. I went through that audit, thought I did real well. The accountant charged almost twice as much what the IRS charged me for representing me at that audit. But then 3 more audits came right on the heels. I guess the IRS up in Washington weren't satisfied with what the field auditor came up with. So I've had 4 IRS audits, both business and personal, in the last year. So the bottom line is, don't take Medicare if you haven't started taking it yet. And for those of you that are getting ready to opt out, be prepared, because to quote Henry Kissinger, the illegal we do immediately. The unconstitutional takes just a little bit longer.
Thank you. Hi, I'm a urologist in Houston, and I thought I was really brave starting a solo practice 6 months ago, and now I'm feeling really brave, and I'm so glad I found everybody here, because Atlas is shrugging, and I love it. And it's so exciting to be with like-minded physicians. It's really inspiring. And I wish for the love of Pete that I had, when I started my solo practice, just started third-party free, but I was just a little bit too scared. So I have 2 questions. One is, when I go third-party free for specialists, do you set time-based fees and, let's see here, what am I trying to say? Fees based on how complex the problem is? Or do you have just one fee for a new patient and one fee for a follow-up patient? And then my second question is, the thing that makes me really mad is that you have to opt out every 2 years. Can't they just leave us alone? And what is AAPS doing on that front to tell Medicare to leave us alone and quit making us slaves even when we're opting out?
Well, I'll handle the question about the office visit charges, and I'll leave the Medicare opting out question to Dr. Orient. But what I do is I have the 5 CPT codes, and I put a price on each one of them. And each individual visit, I decide where the level is appropriate for that particular patient. Now, I'll be honest, I don't follow the Medicare guidelines. I go by my own guidelines. And that's how I decide to charge the patients, and that's how we set up the HCFA codes.
So we get that question a lot, and I think it really varies from specialty. I don't think Kathleen Brown's here. I don't see her floating around. She's cash-only dermatology. So she's mostly fee-for-service as opposed to membership. And I think that's on the one end of the spectrum and primary care on the other, where we're probably 95% membership. We do some DOTs and some basic stuff, but too much fee-for-service kind of cannibalizes the membership. So, and radiology and pathology are going to be all fee-for-service. So cardiology, neurology, urology, probably a lot of urologies are going to be somewhere in the middle, where you're going to say, I do this care for a lot of the diagnoses that are specific to your specialty and are chronic. People are going to see a value in a membership. But for the occasional person who just needs one visit or a consult, I don't think that fee-for-service side affects the membership as much. They're just different values for different populations. So I think in that sense, it's a mix.
But Kathleen was having a problem with the insurers because she wasn't issuing a code and the patients couldn't get anything first.
Okay, yeah. Good point. Apparently, Dr. Brown was having an issue getting with her patients being reimbursed by their insurance company because she wasn't coding. I don't know anything about coding. I'm the wrong guy for that. I haven't coded anything in 5 years. So
the use of the complexity for coding goes back to the RBRVS, and which was really the beginning of the destruction of medical care in America. The idea that certain things were more complex and therefore you could charge more for them. You don't ask a lawyer, how complex is this issue? You're paying them for their expertise, their training, they're willing to take on your case, and their time. And that's, I really think, what we should do as well.
I'm primary care, but I just base it on complexity, but I do the 99212 through 99215. Simple, like you. Just Complexity.
The other thing I would mention as far as surgeries go, there's some things that I think are easier and some things that I think are harder and some things I like to do more and some things I like to do less. And frankly, I charge less for the things I like to do and more for the things I don't like to do. I mean, it's really just that simple.
No, I do that too.
Yeah.
I do.
Hello, my name's Jessica Thomason. I'm a third-year medical student from Texas. I have yet to choose a specialty, and I've had a lot of trepidation in doing so and concerns on whether or not a specialty might determine how I practice medicine, especially for someone coming out with debts and less worldly experience, as some of you might have had when you decided to practice as you do. Do you have any comments on choosing a specialty?
I think I can guess everybody's answer. Family, neurology.
When it comes to practicing medicine freely.
What do you like to do?
So far, I've liked a little bit of everything, but I've had concerns in choosing something such as surgery because of, perhaps overhead cost or equipment,
Don't ignore
things
all
like that.
Ignore all that. The best talk I ever got in medical school was by one of the ophthalmology professors, and he said, "This is how you choose your specialty. You decide, one, do you rather practice in the hospital setting, or do you rather practice in the outpatient setting, or do you like a mix?" And from that, then you also decide whether you want to do surgery or not. And from that, you can kind of decide which specialty you want to go into, because you're going to love no matter what you do. You really are, as long as you get in the right setting. But I wouldn't worry at your stage as far as, what your overhead's going to be and stuff. My
Right.
personal opinion.
Thank you.
Hi, I'm Jennifer Zomner from Frisco, Texas, and I just wanted to say something to the medical student and the gentleman who just got out of residency. I have been in a large hospital-based group practice for 8 years, just resigned, and I'm going to open up my cash practice in February. 10 miles away as per my non-compete in my contract. So for the medical student, I want you to just go with your heart, pick what you love, your passion. You will be able to practice it, you will love it, and you'll find a way to do it. So don't worry about your debt, your overhead. Those loans, they're low percent, you can pay them off forever, whatever. So pick what you love to do. That's what matters the most. For the resident, be super careful whenever you come out, because what is happening in medicine right now is the system is production-based. Production, production, production. They want young, energetic, beaten down, residents that come out and they're afraid, they've got debt, they're used to working 80 hours a week, they're used to working in the ER, they're used to working in urgent care, they're motivated, they're like, yeah, I can come in, I can produce, I can see 25, 30 patients a day. And the system will tell you, you know what, you just come to our clinic, we'll take care of everything for you. You don't have to do anything except practice medicine, what you were trained to do. And they'll give you this nice little contract and you'll sign it, and then all of a sudden you're on the assembly line and you're seeing 20, 25, 30 patients a day, and you're in this horrible EMR system that you can't change. You're seeing your patients during the day in 10-minute office visits. That's where I just came from. We had 10-minute office visits. And you don't eat lunch. You go home at night and you're doing your charts in this horrible EMR. You're spending your weekends, 8 hours on a Sunday for me to finish my charts. And they put you on an RVU model, which if you don't know what that is, you'll find out. And they'll pay you a certain percentage up to a certain number of RVUs, which you can't ever make unless you're just a super producer. And then they dangle that carrot and you can't reach the carrot. And then you get tired or you get educated by people that know more than you that there's a better way. And 8 years down the road, you go, this is for the birds. Like, I'm done with this. And so you are fortunate enough to figure this out right at the beginning, which is fantastic. And I'm so excited. I just wish that I would have found out about this sooner. I mean, literally, I just found out about this maybe like 3 or 4 months ago. And I've been on YouTube watching all these videos, and it's been just fantastic. And my husband, I told him 2 days ago, there's this conference, and it's going to be on Friday. He's like, you have to go. You've been watching those YouTube videos forever. You need to go. So I'm glad that you're here, and I'm glad that you've got this information, and that you're not going to be 8 years down the road finally making the decision. So.
You know,
Maybe you could help us develop a 12-step program for third-party addiction syndrome.
You know, one thing I might add to your comments is, you know, when you do sign that contract with the hospital to become an employee, also down at the bottom is this non-compete clause. And for 2 years, you can't practice medicine in that town, and you have to leave town and leave all the patients behind. So it's not like you're going to build up a practice there and then walk outside and have your practice.
I hate legislation, but because I see it more as a crutch. But we are starting to get a lot of good legislation to be very supportive of direct care, and one of which is, I think, in New Jersey, someone connected with a senator who wants to change the non-compete laws so that if you leave a hospital-based system to go to direct care model, at least it's null and void. I don't know if that'll ever go through, but yeah, avoid those like the plague. I always joke that physicians' signature flaw is we'll sign anything you put in front of us. And that includes contracts. And I don't know how many physicians we could have transitioned into a model, but they were just so locked into an airtight contract that they never even read, didn't know that was in there, just flip, sign, date, like buying a home, and they're stuck. And then echo everything else you said. So.
I'm Judy Thompson. I'm from New Braunfels, Texas, a general surgeon with a non-traditional general surgery practice, but not completely free of third-party payers. I do provide services to cash pay patients, and the way that I decided to bill for my services was based on an experience that I had with a highly respectable and competent attorney. I paid him cash for his services at the time of his service, and so I decided to charge my patients the same thing that I was paying another professional with my degree of competence, and my cash pay patients pay it very gratefully. If it's more money than they can pay, then we sit down and negotiate. So that's something that I have done that works for me. I didn't go online to see what was fair according to Consumer Reports. And also just a little byline, and I have learned that a contract that's being given to me to sign is what's good for them and not so good for me. So I'm really, really contract averse, and that has served me well.
I'm Molly Rutherford from LaGrange, Kentucky, and currently I'm still employed family practice, and I'm also an addiction specialist, so I could probably help with that 12-step program.
You're good, you're on.
We'll meet at the bar later.
But I do encourage you to not sign up with Medicare. Don't sign a contract with any employer. Hopefully I'll be opening my direct primary care practice here in the next couple of months. Yesterday I had to catch a flight, so my employer decided to book me during lunch. I had to see patients during my lunch yesterday, so just remember that they really don't care. But I do have a question. That's actually why I stood up. It's for Josh about dispensing medications. How often do you find that you're not able to provide a medication that someone needs from your office, from your dispensary?
Very rarely in essence. I mean, I'd say it's more medication specific, inhaled corticosteroids, but it's funny, we still let drug reps come by because they give us samples like we're a big clinic, even though we're a small clinic. So I really have to prescribe patients, send them to the pharmacy for inhaled steroids because I get so many samples. So we let them in because it's free meds for our patients. There's a lot of ED drugs until those go generic. We get samples for those, but that's something I have to go to the pharmacy for. Insulin, especially insulin pens. Other than that, we can usually find something comparable. Somebody earlier, all I have to do is present data. I show them, here's your options. I don't sell them on anything. A patient comes in and says, oh, I saw the commercial for the purple pill. I said, yeah, it's $250 a month, and I get generic omeprazole for $1.55. I have a 100% success rate getting them to convert over. Or real recently, Flomax went up from $13 for a 90-day supply to like $60. But I still get finasteride for $4 for a 3-month supply. Again, 100% success rate, just presenting that data. So typically, and when we do, we send them off and we use the service GoodRx to find coupons, and we just want them to get the best price, even if that's not with us. But it's pain medicine we don't do, anxiety medicine we don't do. I mean, just it's in our contract. We don't want to be a cash clinic doing controlled substances. But I would definitely say for our patient population, it's the majority of the time, or minority of the time.
I think this will be the last question, and we have, are we ready for the reception? Okay. Go ahead.
Okay. Hi, I'm Howard Hyde. I'm an IT specialist moonlighting to help my wife and her partner's practice in Santa Monica, California. And I'm curious to know between being in the system versus opted out and cash and everything that we've talked about, do you see a difference in the usage and types of technology, information technology, billing, coding, anything that is strategic or key to making your ideal practice work versus the way it would otherwise work?
Yeah, it's a lot easier when you're out of the system. Well, basically, I mean, everybody's talking about meaningful use. All right? We have an EMR system, but it's a dinosaur of a system that predates any of this stuff. My partner was the second person in the state of Louisiana to have an EMR, and we've had it for a long time. It's a very simple system, but it's real easy to navigate through, and it serves our purposes great, and we're not changing it. What's the name of it, Jim? SecureChart. And the thing is, since we don't have to meet all those milestones, we don't have to worry about the penalties, the audits, et cetera. And so it makes things a lot easier.
And being somebody that actually sees patients in the system and out of the system, I can tell you that when I see a patient that's in the system, my chart note's about 5 pages long. I can tell you whether their dog was spayed or neutered, when their last tetanus shot was. Probably couldn't tell you why the patient was there or what we did for him. But my note for my direct primary care patients is about 3 lines long, saying the patient came in, their blood pressure's well controlled, not having any side effects, follow up in 6 months.
Okay, now this is the very last question. I'm sensing a lot of pent-up demand for the bar service at this point. So you don't want to go beyond like 20 seconds, okay?
I can do faster than that. Explain to me real quick how you use EMR and have HIPAA not applicable to you.
To me? Well, HIPAA is basically transmission of billing to insurance companies. We don't bill any insurance company, so we don't have any covered transactions. We also have we don't take Medicare, which is the other deal, and we have less than 10 employees in the practice. Nope, absolutely not. We constantly look because they change it all the time, and we are not a covered entity.
They do change it a lot.
Yeah.
It just changed recently.
It's kind of interesting, too, because we're on the software side of that. There's a federal level, state level, and then an individual level where, like you said, if you're not a Medicare provider, you're not billing insurance. On the federal level, the billing and the electronic transmission is a key part of that phrase. Some states remove that electronic billing, like Kansas, and if you're a healthcare provider, you're a HIPAA provider. But like most things government, it's minimum code, all right? So the criteria for that are usually pretty simple to navigate, but also our patients have the option to sign a waiver, and that's actually, I can reference the CMS webpage where patients have that right to do. So yes, if you want to text me from your non-secure phone, you can. And once it gets to our stuff, it's fine. We'll go through those steps. And I often reference banking. I honestly think my banking information is a lot more important than my heartburn. So, but they figured out a way to put it on my phone so that I haven't been to the bank in years. Because security is important, but it can't get in the way. And HIPAA is a barrier, not a benefit. It's a 1996 law written when I was 15. The Spice Girls were topping the chart. The Dow was at 6,000, and Internet Explorer 3 was released. So I think it's a little antiquated in a lot of those ways. So it's easy to get around.
Well, I want to thank all of our panelists for a fabulous job. I think you got a lot of great information. They're going to be around, so you can come up to them, of course, I think. Yes. Take reception outside and dinner to follow at 6:30 at the Riverview Ballroom, which is on the way to the lobby.
Because they can violate it if they want. So, yeah, in that sense, I mean, no one's